Bismillahirrahmanirrahim. Mechanism involved in angle closure can be categorized according to the anatomical level, anterior to posterior, at which the causative factors act. Relative pupillary globe. Failure of physiological aqueous flow through the pupil leads to pressure differential between the anterior and posterior chamber with resultant anterior bowing of the iris. Usually anatomically relieved by peripheral iridotomy, which equalizes anterior and posterior chamber pressure. Reduction of IOP will follow, provided the angle has opened adequately. This may not occur if there are substantially peripheral anterior synechium and additional mechanism of angle closure is in effect. Trabecular meshwork damage can prevent the normalization of IOP with an anatomical open angle. The lens bolt quantifies the portion of the lens located anterior to anterior chamber angle. A common definition is the distance between the anterior pole of the lens and the horizontal line joining the scleral spur at diametrically opposite location. A large lens bolt is independently associated with angle closure, though it is not clear whether this is entirely via pupillary block or non-pupillary block mechanism or both. Lens bolt quantifies the portion of lens located anterior to the anterior chamber angle. Lens bolt. Then non-pupillary block, though thought to be important in many Asian patients, associated with deeper anterior chamber than found in those with pure pupillary block. Patients with non-pupillary block, particularly those with plateau iris, tend to be younger than those with pure pupillary block. An element of pupillary block is invariable present, but angle closure is not fully relieved by iridotomy. The term mixed mechanism has been suggested to describe the glaucoma in which both significant pupillary block and non-pupillary block mechanism coexist. Specific anatomical causative factors include plateau iris secondary to anteriorly positioned or rotated ciliary processes, which is shown in the figure 11.35. This is the plateau iris configuration A. High resolution ultrasound showing anteriorly rotated ciliary processes and slit-like angle. Gonioscopic appearance show chronic closure. White arrow show the border between the closed and open angle. Note iris processes. A concept of thick peripheral iris rule has been introduced by some authorities. Thick peripheral iris may be relatively important in Asians. Plateau iris configuration is characterized by flat or only slightly convex central iris plane, often in association with normal or only slightly shallow anterior chamber depth. The angle recess is typically very narrow, with sharp backward iris angulation over the anteriorly positioned ciliary processes. Characteristic double hump sign is seen on indentation of gonioscopy. The central hump being due to underlying central lens supporting the iris and peripheral hump resulting from the underlying ciliary processes. Plateau iris syndrome describes the persistence of gonioscopic angle closure despite a patent iridotomy in a patient with morphological plateau iris. Factors such as darkened environment or pharmacological pupillary dilation may be necessary to demonstrate the angle closure. It is divided into complete form, in which occlusion of the functional trabecular meshwork is present and IOP is elevated, and incomplete form with occlusion to lesser extent and normal IOP. Lens induced angle closure. Angle closure that is predominantly lens induced due to retrolenticular causes often categorized as secondary. This includes those cases in which sudden change in lens volume or position cause an acute or subacute IOP rise, usually rapid progression of lens intumescence, phagomorphic glaucoma, or anterior lens subluxation. All cases of pupillary block have a pharmacomorphic element that increases with age as lens thickens. Retrolenticular is malignant glaucoma. Ciliolenticular block, posterior segment causes of secondary closure glaucoma. Combined mechanism as a formal level for a combination of angle closure and open angle Reduced aqueous outflow has been postulated to be caused by following mechanisms: appositional obstruction of the iris, degeneration of trabecular meshwork due to chronic intermittent contact with the iris or sustained elevated IUP, permanent occlusion of trabecular meshwork by peripheral anterior in prognosis control correlates well with the extent of ES. Now, what are the risk factors? Risk factors: average age is about 62 years at presentation of relative pupillary block. Non-pupillary block forms of primary angle closure trends to occur at younger age. Relative pupillary block at 62 years and non-pupillary block at the age of younger age. Gender: females are more common than the males. Race: particularly common in Far Eastern and Indian Asians, where non-pupillary block is relatively more significant. Family history: genetic factors are important, with increased prevalence of angle closure in family members. Eyes with pure pupillary block are usually hypermetropic. Non-pupillary block mechanism can occasionally occur in myopic eye. Up to 1 in 6 patients with hypermetropia of one diopter or more, a primary angle closure is suspect, so routine corneoscopy should be considered in all adults who are hypermetropic. Axial length: short eyes tend to have a shallow AC secondary to relative anterior lens position. Eyes with nanophthalmos, axial length less than 20 mm, have a very short eye and are a particular risk. So these are the risk factors. Age: 62 years of pupillary block and younger age for the non-pupillary block. Female gender. Race: particularly Far Eastern, Indian Asian. Family history: positive in family members. Refraction: pure pupillary block usually hypermetropic. Non-pupillary block mechanism in myopic eye. Axial length in nanophthalmos.